Radiology Artificial Intelligence, Bits and Bytes. I'm Pedro Stasiaki, Trainee Editorial Board Member. Combining initial radiographs and clinical variables improves deep learning prognostication in patients with COVID-19 from the emergency department. Radiograph is the primary imaging modality in COVID-19. It has limited sensitivity, but it is useful in prognostication. Deep learning is a type of AI that has multi-layered neural networks and is able to automatically extract high-level features from data. It has been used in X-ray to predict outcomes in COVID. The purpose of this work was to train a deep learning algorithm to predict outcomes in patients with COVID-19 using X-ray and clinical variables from the ED, and to compare the performance between X-ray and clinical variables alone versus a combination of X-ray plus clinical variables. This was a HIPAA-compliant retrospective cohort study that included patients ages 21 to 50 presenting to the ED in a multi-center urban health system from March 10 to 26, 2020. COVID-19 was confirmed with RT-PCR. Exclusion criteria were patients older than that or younger than 21, duplicate chest radiographs in the same patient, unconfirmed COVID-19 RT-PCR, presentations unrelated to COVID-19, unevaluable chest X-rays, and inaccessible clinical data. Variables and covariates were collected within 30 days and included the X-ray information, clinical variables like white blood cell count, lactate, etc. Outcomes included admission, intubation, and survival. The chest severity score utilized was previously reported and validated and divided the lung into 3 zones, and a binary score was given for each zone amounting to a total of 6. 2 or more was considered severe. This is an example of a severity score of 4. This is an example of a severity score of 6. The ground truth was the independent examination and scoring by 2 different cardiothoracic radiologists who were blinded to patient history. They scored zones that they agreed on, otherwise the lung zones were deemed normal. This was a deep learning algorithm that had a training set of 84%, validation set of 16%, and additional patients from March 27 to 29 were held out for the test set. Raw metadata was de-identified and embedded test was removed. Images were converted to tensors and normalized with the ImageNet, and images were stored as HDF5. The model was first pre-trained on ImageNet, and 2 different labeling schemes for training were utilized: DenseNet 121 output compiled by fully connected layer, and a sigmoid function to generate a probability score for the label. For both chest X-ray and clinical variables were concatenated and added as input before the fully connected layer in the classification layer of the model previously trained on the X-ray and severity score. For model evaluation, we used ROC areas under the curve, heat maps using a descriptive localization method, source code publicly available. 499 patients were included, median age was 42, 308 were men, and about 50% had severe X-ray. The concordance between the 2 chest radiologists was over 90%. Data partitioning amounted to 283 patients in the training set, 55 patients in the validation set, and 161 patients in the test set. For prediction of X-ray severity, AUC was 0.8 trained on severity and 0.7 trained on admission. For prediction of admission, AUC was 0.76 for patients trained on severity and 0.7 for patients trained on admission. For prediction of intubation, AUC was 0.66 and 0.58 respectively, and for death, 0.59 and 0.50 respectively. For prediction of intubation using 2 categories, a combination model performed better. The same thing happened for death. And in the heat map, yellow indicated greater contribution to final input, purple less. Irrelevant areas were not contributed substantially to the final output. Value of the model output probability increased with worse clinical outcomes. This is an example of a score 0, admission was also 0, intubation 0, death 0. And you see in the panel that mostly it's purple, whereas this case, a patient who was admitted, intubated, and passed away, these are all yellow panels. The strengths of this study were the ability for the deep learning model to predict clinical outcomes rather than only screen for or confirm diagnosis of COVID-19, the use of multiple hospitals across 3 New York City boroughs, the diversity of X-rays and test cohorts, which leads to generalizability, and use of heat maps to ensure that the appropriate regions of the X-ray were contributing to the final predictive output. Limitations included no inclusion of patients without RT-PCR confirmed COVID-19. It was trained only in patients aged 21 to 50, and a small number of chest radiographs. So in conclusion, this was a proof of concept DL algorithm able to predict clinical outcomes of adult patients with COVID-19 using only the routine X-ray and ED lab studies. Combining chest X-ray plus clinical variables provided the best model performance for the prediction of intubation and death. Combination of imaging plus clinical data can help predict clinical outcomes in COVID-19 and can help triage patients for optimal care.